Please welcome Dr. Thomas Insel.
Well, thanks, Jonathan, and what a treat to be here. I respect this. It's probably since it's Veterans Day, many of you have other things to do today, so I really appreciate your joining for at least this hour. And what I'd like to do is talk a little bit about what's in the book, and then some thoughts about what I've learned since, and maybe kind of open this up and convert it into more of a conversation because I'm sure all of you come to this topic with a lot of experience and wisdom, and I'm eager to learn from you as much. And I say that because NAMI has been for me and really an inspiration all the way through my career. It's been a way to hear what it is that families have understood about mental illness. And if there's one thing that I learned in the process of working on the book, it was the extraordinary way in which we in mental health have tended to exclude families, even though they're often the coordinators of care, the navigators to care, the managers of care, the people who have a deep insight into what is most helpful for the one they love. And yet, for a variety of perverse reasons, they've never been part of the care team in mental health, the way they might be in cancer care or other parts of healthcare. So, if you're okay with this, let me start. I'll share some slides, and we can use those as a basis for our conversation. Let me make sure I can get these to come up. Here we go. Are you able to see those? Is that clear? Awesome. Okay. So this is the book that we were just talking about, and the impetus for this book in many ways was having spent, as Jonathan mentioned, many years running the National Institute of Mental Health, which was mostly a research institute. It felt to me like we had sort of been through this golden age for science, and in many different areas of science. We had made just enormous progress, in some ways historic progress, like we hadn't seen at any other period of time. And yet, it's difficult to make the claim that we've seen that same kind of progress in the world of mental health care or in clinical psychiatry. As the book came out, we had a Surgeon General and a president and many other people talking about a mental health crisis. This was sort of coming out of COVID, and there was a sense that we really were in a crisis. It's probably best for our conversation to think about this not as a single monolithic crisis, but it's really three different kinds of crises. Hold on just a second here. So one aspect of that crisis is really captured by these deaths of despair. Angus Deaton and Ann Case have written about this, and you can see it in the numbers, the suicide, drug overdose, alcohol, mortality numbers. As it says in the slide, these were actually lowering life expectancy even before COVID. But with COVID, the numbers continue to surge. We don't have 2024 or 2025 numbers, but if you can look at 2023, it's pretty extraordinary. We're like, 4 to 5 times where we were in the year 2000. Probably the alcohol numbers are hard to compare because it's kind of apples and oranges. But if you just look at drug overdoses from 17,000 to 105,000, or suicide numbers, which are up the highest they've ever been, actually, as far as we know, in the United States. And it's really interesting because that massive increase since 2000 in the US contrasts with what we've seen as a pretty striking decrease in suicide rates in most of the developing world. So we're kind of an exception with these high rates. But as I was saying, it's probably not a single crisis. They're probably best to think about this as three different, I call it the trifecta of the mental health crisis. The youth mental health crisis, the SMI or serious mental illness crisis, and the SUD or substance use disorder crisis. And the reason I separate them out is they each actually have different drivers and may each have quite different solutions. We know that the youth mental health crisis is continuing to grow in terms of prevalence. A lot of this is just huge increases in numbers. It says here 52% increase in the rate of suicides, about 100% rate in the increase of ER visits. And the number of people in care itself is up something like 300%. It's really kind of extraordinary. The story is that it's more young females more than young males. We know that most of what we're seeing are kind of what the psychologists would call internalizing disorders, not acting out, ADHD, impulsive kind of stuff, but much more high rates of anxiety, depression, panic. Certain populations much more affected, particularly when you look at suicide attempts and suicide mortality. The LGBTQ population by far and away exceeds any other subgroup amongst youth. Now, that picture is quite different from what we see for serious mental illness, which is not really a huge increase in prevalence. I don't think there's any evidence that the rate of schizophrenia or bipolar disorder has gone up very much over the last decade or two. In fact, it's probably not changed very much over the last 1,000 years. It's still about the same prevalence that we're used to. What's happened, and the reason that's a crisis, is really because of our failure to really provide the kinds of things that people with serious mental illness need. So we've seen increases in incarceration, increases in homelessness, and actually a remarkable, it's not so much an increase, but a continuing high rate of mortality, about a 20-year reduction in life expectancy, which is just extraordinary. It sort of means that people with SMI are dying at about the rate that the whole population would have seen in the early 1900s. So we've lost a century of medical progress. And they're not dying so much from suicide, but from common medical problems, mostly pulmonary disease, cardiovascular disease, sometimes metabolic disease. SUD is substance use disorder is really a very different story altogether. That crisis, which is huge increase in mortality, as you saw in the previous slide, up to in 2023 was 105,000. Last year, the death rate came down significantly to 70,000, but still really, really high mortality. Again, unique to the United States. I was just in Europe. I was in Switzerland. The number of overdose deaths they have each year, you could probably, it's in the hundreds, not in the tens of thousands. And the rate is much, much less all through Europe. This story is largely, again, a fentanyl story. So it's not so much that we're seeing massive increases in drug abuse or drug addiction. It's the use of fentanyl, which is so lethal, has really driven so much of that crisis. So 3 different pictures. There is, of course, some overlap, and there are places where you can actually find a young person with SMI and SUD. That's not that uncommon. But I do think it's best to separate them out. Also understand that together they're really driving very specific public health problems right now. The emergency room boarding crisis is massive and it's national, and it really has not yet been solved. So people are spending 3, 4, 5 days sitting in emergency rooms, huge demands for crisis services through 988. Large cost demands. And I was just at a meeting today in San Diego. They're reporting 40% increases by insurance claims for behavioral health over the last 5 years. So these are really striking pain points for the payers. And the reality is, while we're spending more money, our outcomes are actually worse, not better. So that's not the place we want to be. So I want to just take maybe 5 minutes and talk about how we get into this pickle, which is a lot of what I write about in the book, and then take the rest of the time to talk about how do we get out of it and what do we need to do. The first thing and I'll focus mostly on this SMI piece because it's probably the most NAMI related. Um, I often talk about this as really a care crisis, not so much a typical public health crisis like a pandemic, because this is really not so much about the disease increasing or emerging. It's really about our failure to take care of the people with this disorder. I spent about a year working for our governor here in California, Governor Gavin Newsom. He asked me to sort of just drive up and down the state and be his eyes and ears on this crisis to try to figure out why are we having this problem? And I went into that thinking I knew the answer. I came out of it really surprised, mostly realizing it wasn't one thing. It's probably five different things. And I want to take you through what those look like. One was just a simple lack of capacity. We don't have the beds, which is why people end up in the emergency room. We often don't have the workforce we need. And the safety net that I knew about when I was first becoming a psychiatrist has largely been shredded. So there's just no place for many people to get care. We amazingly don't engage the people in the way that we need to. It's very interesting to me that um, mental health is so different from any other part of medicine. Generally, in the rest of healthcare, the sicker you are, the more likely you'll be in care. Here, it's just the flip side of that. As you get more ill, it's probably less likely that you'll be in care. We talk an awful lot about access, but actually a bigger problem is the engagement. People with depression or hopeless, people with anxiety or avoidant and fearful, and people with psychotic illnesses may not think they're ill, and that is a massively big challenge in this field that you don't see elsewhere in medicine. So I want to talk a little bit more about that in just a moment. When people do seek care, the quality ain't great. What they get is a very fragmented system that's very reactive, often crisis oriented, and not a lot of accountability. Frankly, for most of mental health care, unlike what we would expect for diabetes or hypertension or almost any part of medicine, there's no accountability to certain outcomes. And finally, there's an equity issue, not in the sense that people talk about equity today, as kind of racial issue. This is really about how people with serious mental illness have become a kind of maybe one of the most marginalized groups in our society. I mean, there's all this conversation today about mental health. You can't watch a football game without getting some public service announcement about mental health. But what nobody really wants to talk about or even address are the needs of people with serious mental illness, and they still remain very much on the margins. So give me a couple minutes here just to unpack each one of these, because I think it's good to have at least a visual to take away before we talk about the solutions. I'll do it really quickly. The capacity issue, as I mentioned, the no beds, the beds have disappeared really in with deinstitutionalization. We now call it transinstitutionalization because with the end of the state hospital system in the 60s and 70s and 80s, because of the community mental health system, a federal approach to mental health, there were really no hospital beds left. And what happened was that people who previously were hospitalized ended up being incarcerated. So at the same time, the state mental health state hospitals disappeared, the jails and prisons, of course, increased in such a massive way. And so on any given night in 2025, you're probably going to find 10 times more people with serious mental illness in the criminal justice system than in the healthcare system. I would say that it would be unthinkable to think that way about any other disorder in medicine, but we have largely criminalized is partly just from the lack of capacity. In fact, we don't have mental hospitals. We don't have the beds, and we need them almost in every part of the United States. We also don't have the workforce we need. This is just a, a RAND Corporation study from last year. And they looked at the counties either as metropolitan or suburban or rural counties. And you can see, like in a place like New Mexico, where you've got a lot of rural counties, that most of them are not going to have psychologists, psychiatrists, or nurse practitioners, which we know is the backbone for mental health care, particularly for people with SMI. Engagement. I talked about this before. I said 60% of people are not getting care. What that really looks like, if 40% are getting services, the work we did at NIMH suggested that only about 40% of those are getting evidence-based, minimally acceptable care. And of those, about a third get well, a third get better, and a third don't really get benefit. So in the book, I call this the 40-40-33 rule. You just do the math, it's about 6%, 0.4 times 0.4 times 0.3 is where you end up, 5-6% of people really getting full benefit. This was something that I think NAMI really needs to embrace, because I got to say, I really missed this. And even when I did that tour for the governor, when I talked to psychiatrists and nurses and providers, they all said consistently, we're doing a great job. And we're doing so much better than we were when I got into the field 10, 20, 30 years ago. I actually went back and interviewed people that I had trained with in the 1970s. And every one of them said, it is a different experience today. We can help so many people. We really help people recover. And I get that. I think that's really true, but they're seeing 6% of the population. And what they don't see are the people that are not showing up at their door. And that's part of this crisis that we have to understand. It's even worse for kids. That's like 20% engaged. And for substance use disorder, you can see the numbers are even more dire. This is a big, big problem. We don't talk about it very much in mental health circles, but we talk a lot about making sure we have a bigger workforce, making sure we have access. It's engagement that is really the key to population health. Don't need to spend a lot of time talking about quality. You know this, that it's like if you've got a loved one who's trying to get care, it just isn't great. The standards are much less than what we'd expect anywhere else in medicine. Most therapists aren't providing even the basic of evidence-based care. Very few people with SMI or SUD get recovery services, which we'll talk about. Accountability, I mentioned that we're not measuring. About 20% of practitioners actually measure any kind of outcome objectively. Again, hard to imagine that for diabetes or hypertension, but that's the unfortunate state of the art here. And it's one of the reasons we haven't made more progress. And then finally, I mentioned this equity issue. And for the sake of the book, I thought about people with serious mental illness. For a moment, I sort of thought, what if they were a racial ethnic minority? How would they square against the racial ethnic minorities we usually think about? And it's pretty stunning that in terms of life expectancy, employment, the relative risk of use of force by police or incarceration, they really do look like our untouchables. I mean, they really are worse off than virtually any other group. And of course, if they happen to be Black or Latino, it's even worse to have SMI. So those data are really worrisome. Okay, that's the painful part I had to get through, because I do think we have to be realistic about just what we're facing and what's the problem or the list of problems that need to be solved. But let's talk about the solutions, because I'm actually a hopeful guy and I think there's a lot to offer here, and it's a really exciting time right now. And we'll run through this kind of in the same way. I want to start by just suggesting that, and I talk quite a bit about this in the book, that there's some things we just don't usually think about here, which are really quite different than what you'd see elsewhere in medicine. One is that um, some of the best providers are the least expensive, that peers and coaches are really able to take us quite a ways. They're not the whole story, but they're a bigger part of the answer here than they would be, for instance, in cancer care or let's say cardiovascular care. Um, some of the interventions that are really going to be important for solving the crisis are non-medical ones. So I'm a huge fan of the Clubhouse movement. I'm trying to remember. I don't know what we have in New Mexico with clubhouses. I'm on the board of a clubhouse in New York called Fountain House. We've gone national. We have about 9 or 10 clubhouses around the country. Um, and it's been stunning to see how well those are able to help with recovery, housing, AA. There's just a whole bunch of stuff out there for in what I'll call psychosocial rehabilitation, which is really important and really effective. And then something we often forget is that some of the people who you see who seem the most disabled in this field, maybe they're homeless, maybe they've been incarcerated, maybe they're really hard to engage. But if you can get them engaged in care, there's every reason to think that they can recover and actually become part of the solution, not just a problem. And that for me has been one of the real inspirations for doing this work, and for um, wanting to make sure that we think about how we help people with SMI. Um, Says here in the tagline, we don't need to spend more money. Actually, we probably do, but we do need to make sure that we're paying for the things that work. We're paying for a lot of things right now that don't. And oddly enough, as I'll say more in a minute about this, some of the things that I've just mentioned, like clubhouses and AA, and a lot of the things that are most effective, we actually don't pay for. And so it's often difficult to get them delivered. The second big piece, besides those kinds of unexpected aspects of this mental health field, is that we're in the middle of a real innovation moment for mental health. And some of this has to do with the transfer of care from being in the brick and mortar environment to an online environment. But that's just the very beginning. I think, telehealth will now can become very, very different, particularly with artificial intelligence and natural language processing, allowing us to capture data in new ways, beginning to use things like speech and voice and face emotion to help with diagnosis and help measure outcomes, collecting wearable data using scribes so that you don't have to spend a lot of time on the administrative part of documentation. So there's just a huge opportunity now to transform mental health care in a way and mental health diagnosis and even mental health, actual treatment in ways that we couldn't have imagined a decade ago. And if you begin to put those things together with that problem set that I've already described, it's actually a pretty hopeful story. So um, I would say for each one of these things, we've got something to offer. On the capacity side, it is literally investment. We've got to start spending the money to build the stuff that we need or that we've lost. On engagement and quality and accountability, technology can take us a long way in giving us the kinds of solutions we need. And I'll say a little bit more about that in a moment. And then even with equity, there's a way to change the nature of care so that we get recovery as an outcome. And that's something that I didn't appreciate fully before writing the book, but I have become a complete convert to that kind of recovery approach since writing it and since working in the field in the last 2 or 3 years. Again, I want to just quickly unpack each of these to give you some detail about what that means. For investment, it's just wild. We've seen venture capital and philanthropy jump into this space particularly since COVID, in a way that I don't think any of us would have imagined 5 years ago. So it is about 12, maybe now $13 billion over the last 5 years for venture capital. And that number, 2.3 billion in philanthropy, is going to go up quite a bit, I think, in this 2025 as those numbers come in. It's also massive increases in federal spending. And New Mexico is a good example of this. The CCBHCs, these are the Certified Community Behavioral Health Centers, are now roughly probably altogether a $10 billion project, which is kind of like what we saw in the 1960s and 70s with a federally funded community mental health program. And the CCBHCs, in so many ways, are addressing almost all of those pain points that I mentioned before for SMI. SAMHSA has grown. That's the agency in Washington that funds a lot of mental health care and substance use disorder care. It's grown by threefold. That is probably going to be undone over the next few months. So a little hard to know where that's going to end up. And CMS, which in all the years when I was in the federal government never seemed to be too interested in mental health, they've really stepped up and they're doing a huge amount. Again, we have to hope that that continues. There's been some state funding. New Mexico's got this SB3 this past year to increase investment in mental health. And it's not huge. I think it's about $29 million, but that's something that we didn't have before. If we look at those other issues like engagement, quality, accountability, just summarized for time, because I want to make sure we have some conversation here. But we've got really a whole range of things, the mobile interventions, that moving to telehealth with being able to meet people where they are and give them the kind of care that they have control over so they can get it when they want it. Sometimes it's asynchronous. It's turned out to be massively successful, much higher rates of engagement. The quality is still an issue that we need to continue to work on, but at least being able to capture the data in new ways, including things like which we call digital phenotyping, capturing voice and speech, things I just mentioned with AI. All of this really gives us the beginning of a new kind of mental health system. I like to call this a learning mental health system because we're beginning to do here what we've done so well in diabetes, which is being able to, at the individual level, measure outcomes. And then if, blood sugar or hemoglobin A1C gets too high, then you increase the insulin dose in a kind of closed loop system. We're getting to that here, I think, and the digital piece, the technology really helps us to be able to think about this in new ways that we really were not even on the map 5 years ago. This whole business with AI, we should talk about this because it's in the news so much. There's virtually not a day that goes by without some story about AI and mental health. Most of those stories are frightening about how somebody's used AI and they've become psychotic or they've developed some delusion with AI. In some cases, it's AI encouraging someone to suicide. There are a bunch of court cases now looking at this, and several states have actually banned the use of AI for therapy or diagnosis. It's kind of wild because in the meetings I go to, people are super excited about AI for healthcare, but when it comes to AI for mental health care, it's whoa. Let's be really thoughtful. Let's be really frightened here. I'm actually I see this in a very different way. I mean, I think with any technology, you have to understand the risks and the benefits. In this case, I think those benefits have to be compared to what the status quo is. And the status quo is so bad that we are already seeing areas where AI can do much, much, much better. So that has to do with how we do diagnosis. And I won't take you through all the words here, but there's just great opportunities to collect the kind of data that allows us to get much more precise about mental disorders and how we label them, what the diagnosis is. all of the documentation and the kinds of things that are taking up a huge amount of time for our providers on the front line. Here in California, our frontline providers spend 50% of their time in documenting what they do the other 50% of the time. That can just be offloaded to a digital scribe. We essentially double the workforce with the use of AI. Where it gets kind of funky is around the treatment issues. And could you use AI, actually, a bot for therapy? Most of the interest right now is in bots that are kind of clinician facing. So they help with either the scribes, they help with documentation, or they help with decision support, or they help with training the workforce. Those are all really great use cases. The idea that you could use a bot, an agent, to augment what a clinician does is still a little bit slow to develop here, but I think it's inevitable, and we've already now are seeing the first research studies that demonstrate that instead of seeing somebody once a week, you can for 50 minutes, you can see them every other week for 25 minutes and provide AI journaling and an agent to check in and training and homework support with an agent and a whole bunch of other things that give you very much the same outcomes. So lots of ways to expand the workforce, expand what people are able to do. And ultimately, potentially, there's going to be an opportunity to use agents and AI bots without having to have a human in the loop. We're not quite there, but I don't think it's unimaginable. And again, it's always a question of compared to what. There will be risks with that, but there are ways to mitigate those risks, which we can talk about. Last thing, just to wrap up here, this business about equity and recovery-based care. Again, while working on the book and working for Governor Newsom, I spent some time on Skid Row in Los Angeles. It's really pretty shocking to see the state of play and the number of people living in these encampments who have untreated serious mental illness. I was there with a guy named John Sharon, who was running the Los Angeles County Mental Health Department. And I asked him kind of how he thought what we needed to do differently. He said, we got to focus on recovery. When I said, well, what do you mean by recovery? He said, it's really easy. It's just the 3 Ps. And of course, I was thinking about Prozac and Paxil, and he was saying, no. It's people, place, and purpose. These folks don't just need medication; they need social support. They need a safe environment, and most of all, they need a purpose. They need to have something to recover for. And I found that incredibly helpful as a way of trying to understand really how to deal with the SMI crisis and maybe the SUD and youth mental health crisis as well. That these 3 Ps explained a lot of what we had been missing. We know how to do this. It's not a research project. It's really an implementation question. There's a series of very effective interventions. I mentioned before psychosocial rehabilitation. That would be like the clubhouse, family education, supported employment, supportive housing, an ACT team, which is really for engagement. So not just waiting for people to come to the clinic, but going and meeting them where they are. And then, of course, medication and cognitive support and all of that. The issue is that really, even though we know how to deliver these, we don't do it because of the fourth P of payment. We don't really reimburse for the clubhouse or supportive employment or supported education. Now we're doing some housing, but these are really critical in the same way that you would think about nutrition counseling for diabetes. This is, or even physical rehabilitation in orthopedics. You need this. You need this whole toolbox. And some people need different parts of it. But all of this is what you need to create a system where people recover. And we need to pay for it, and we need to scale it and make sure it gets done. So the way I think about this is that since I really come at this as a neuroscientist, I actually think that it's best to talk about mental illnesses as brain disorders. I think they are medical disorders, and the problem I would define as medical, but the solutions are much broader than that. And the three Ps are one way to think about that is there's social solutions, environmental solutions, and ultimately political solutions, which have to do with payment. Um, Most of all, I think, if we get locked into a strictly medical model, then we end up just trying to reduce the symptoms. And I think that works great in infectious diseases and maybe in even cardiovascular medicine and certainly in orthopedics. It doesn't work here. It's just, I mean, that's what we're learning. That's why we have the care crisis, is because we have been focused on reducing the symptoms and on really helping people to recover. And that really means we have to change the way we think about care. So if we think about those three original, that trifecta that we talked about in the beginning, and we take this new lens, there's absolutely stuff to solve every one of these. Again, it's not an R&D problem. It's an implementation problem. It's an investment problem. It's deciding that this is important enough for us to do it. We know what needs to be done, but we haven't done it. And I think that really does answer the original question of why we haven't made more progress and why we're in this crisis. We need a different care model. We have to move to focusing on the three Ps and not just the traditional medical model. And we need to pay in a different way. And we need to pay for results. And that includes paying for that whole range of psychosocial services like the clubhouse and supportive employment, all of that to help people recover. And ultimately a different kind of model that looks upstream as well. We have gotten so wrapped around 988 and crisis services without ever asking, why do we have a crisis to begin with, and why aren't we doing more to prevent a crisis? So I do think going forward, we want to think about that other P besides payment. We also have to think about prevention. So let me stop there. I'll stop sharing and let's move this to more of a conversation. Thanks so much for sticking with me as I went through all of those slides.
Thank you, Dr. Insel. That was wonderful. So please, if you have a question and you want to raise your hand, you can also put it in the chat box, which I forgot to ask you to do at the beginning, so forgive me. But this is a great opportunity to ask and have a dialogue with Dr. Insel about what he just talked about.
I
Any
hope I
questions?
haven't put you all to sleep.
No, no, no. I mean, let me start it out. Wait, one of the things I've seen of the quality of care measures that I've seen in my practice as a family doc, and sometimes in psychiatry as well, is the use of tools like a PHQ-9 or a GAD-7 or something like that that measures how your treatment is doing for that patient. And it often doesn't measure how that patient is actually doing and measure how your treatment is doing. And sometimes they don't mesh. And for example, patients will say, I did well on this test, but I don't feel much better. You know? So how do we reconcile how we measure how we're doing from the patient's perspective?
Yeah, it's I have a company that I launched earlier this year called Benchmark Health, and a lot of what we're trying to do at Benchmark is to change the outcomes to really create the measures that matter for patients. Um, and the way we haven't completed this task, but what we're working on now is getting away from those kinds of symptom scales like PHQ-9 and GAD-7, which actually don't mean a hell of a lot. And they're not correlated with things you care about, like is somebody back in school? Is somebody back at work? Are they able to take care of their family? I mean, all the stuff that really matters to patients. So what we've done and what NCQA, which is the group that sets standards for healthcare, like the HEDIS measures and all that, they're doing this with us. is creating what they call goal attainment scales. And the goal attainment scale is really starting off by asking the patient, what does success look like for you? And it's rare for a patient to say, I want the voices to stop. What they usually say is, I want to have a date. I want to have a girlfriend. I want to have a life. I don't want to, I don't want to live like this. And so helping patients right from the get-go, at the very beginning, to sort of set a goal and set a timeline. I'm in the tech industry. So in the tech world, we talk about OKRs, objectives and key results. And that's the way we manage companies and manage teams in tech world. We can actually, that's not a bad way to engage patients and families in thinking about what are we trying to do here? And it's not, a 25% reduction on a symptom scale. It really is something that's much more important in the way that somebody wants to live. One of the things I put in that circle diagram of the psychosocial rehab stuff that I didn't explain was so-called a resource group. Resource group is actually not used much in the States. It's something NAMI is kind of getting to, but it came out of Scandinavia, and what they do there for young people, especially who have a first episode of psychosis, or actually anybody with SMI, is as they're recovering, they put a group together. It's usually parents or some family member, a friend, if there is one, somebody from the treatment team, maybe a teacher from school. It could be, it's a group of 4, 5, 6 people, and together they develop kind of OKRs. They say, like, what are we trying to do here? Where do you want to be in 3 months and 6 months? And how can we as a team make sure you get there? You
Right.
tell us what you need, tell us where you want to be. I think that's just like a very different way of approaching outcomes. We do this a little bit in orthopedics where we ask about functional outcomes. Somebody says, for me, success will be if I can run a marathon, or I can, I want to be able to go back and run a 5K again. And we work towards that with physical rehab. All I'm suggesting here is we do basically the same thing, and we use psychosocial rehab to get somebody to their 5K.
Tom, we have a question from let me bring it up. Melissa Calhoun, who says, I work in homelessness services. What services are there that we could use to assess how well our services, mostly external, are doing? And do we have to be professionals to administer them?
Yeah, well, certainly when we think about how to administer, it's usually a team, right? And part of the team, I think all the evidence says that one of the ways to do this well, to get engagement and trust, is to include peers, people who have been homeless, and make sure that they're part of the team. They don't need to be the whole team, but without them, most people find it's difficult to be able to get adoption and get the trust that you need. In terms of what resources are there, there's always this debate about housing first, getting people into housing. This is an issue in almost every part of the country. Um, but it is kind of where you have to start. I mean, without the housing to go to, it's already hard enough to get people who are unsheltered often into shelter, but you do need to have those resources to be able to address the problem. I think, again, there's some debate in the literature, but most people would say that the housing first approach is a great way to go. You get somebody into a place where they're sheltered and then get them all the services they need. The one thing I want to stress that I think we've learned for SMI is that housing first is important. It's not enough. And one of the ways that we've addressed this, for instance, at Fountain House, where we deal with a lot of people who've been incarcerated and homeless, is that what they really need is not just housing, but community. We call it intentional community. And in the Bronx and in LA and a few other places, they tend to be like 5-story buildings, 4 floors of residences, almost like a dormitory. And the first floor is the clubhouse. And it's been fascinating to watch how this works, because the clubhouse is where people go every day and they get their meals and they get they help with job training and job applications or education, whatever it is that they need. They get all three P's. But what's really amazing is when you provide the housing as well, how much they create communities within that housing piece, even outside of the clubhouse. So kind of like a college dormitory. And that I do think is the model that we want to move to, but we have to figure out how to pay for it.
Other questions for Tom?
So I see there's some in the chat from Tom Chesney about excellent presentation. It helps reaffirm the educational mission and goals of my college to continue preparing therapists and counselors to continue this work with compassionate care, new methods of hope. Okay, Tom, any questions about that? Or because I do think those are, having hope here is like really, really, really key. Yeah, Melissa asked about challenged who need high levels of
Yeah.
services to stay housed, and what do you do when you're small and rural? And this is was a question I wanted to ask you. I think it's so the clubhouse movement has done really well in New York and Phoenix and now in Los Angeles and Columbus, in some major cities. So in New Mexico, I mean, you could do it in Santa Fe, you could certainly do it in Albuquerque, but for rural areas, not so clear how well that works. During the pandemic at Fountain House in New York, we moved to having remote services, and that worked great. We actually didn't expect it to work, but it worked really, really well. I don't know though how much of that was because people had already created a community and now it was just extending that through Zoom. Whether I'm not sure how well it would work to whether you can do the three Ps remotely. I kind of doubt it. I think you need high touch, not just high tech. So I think we've got to get smart about that. Oklahoma has done some really interesting stuff. I love the group at Grand Lake in northern Oklahoma where they've developed through their CCBHC a set of services for the rural counties, mostly using technology. And I got to say, the results are pretty extraordinary. So that's a good model to look at. Which reminds me, do you guys know what the CCBHCs are and what they do? And do you have them, I believe, in New
Yes, we have
Mexico?
them. We have,
Yeah.
yeah.
So I want to kind of endorse that as I think for NAMI, it's probably the key service or set of services you need. The way these were set up, there's a list of services that are required to be provided. Some relate to primary care, some to crisis care, some to outreach. Um, and you put all that together, and it really is pretty much the what I described in that wheel of fortune, the things you need for psychosocial rehab. What they're missing is they don't do enough with the like clubhouse. They don't quite get all three Ps. Developing purpose, they're still not really thinking enough about that. But with the CCBHCs, you have an opportunity to get into what's called prospective payment for the states that have the demonstration model. And that allows you to pay for stuff that normally wouldn't be paid for by Medicaid. Also allows you to get an enhanced rate for Medicaid. So that's a super interesting and I think one of the most exciting opportunities. With this new administration, they're going to gut SAMHSA, but they're putting $50 billion with the big, beautiful bill into the rural health transformation grants. And those $50 billion specifically earmark for rural states the opportunity to use FQHCs, the federally qualified health centers for primary care, and the CCBHCs. They want to see more of those. So it's something to think about in New Mexico. If you get a partner, maybe through UNM, to work on creating CCBHCs through the rural transformation grants. The initial proposals, I think, are due in December. And that is the one growth area that for the federal government in healthcare in this administration. And it's nothing to sneeze at. 50 bill is a lot of money.
A lot of money.
We
Tom,
have we have five CCBHCs in New Mexico.
But I don't think New Mexico's a demonstration state yet, is it? Do
Yes,
you
I
know?
think, yes, I believe it is.
Is it big?
Or-
Okay. Yeah, that's great. So
Yeah.
then you could build upon that. So I would say if you have five, see whether there's a way to fund an additional five through the rural transformation grant. These really, when I wrote the book, CCBHCs were really just getting going. They just had the first 10 states, and I got access to a lot of their data. Initially, it wasn't great, honestly, because they didn't quite have the model right. But
Mhm.
I think we're in a
Yeah,
great,
slow start too.
yeah.
yeah.
Tom, just before I'm going to ask Craig O'Hare, he has a question, but just the 29 million that you talked about for SB3, the 29 million is actually just an exploratory fund. SB1, it's just a way of writing a check to begin it. The total outlay for SB3 is $1 billion.
Hmm.
So it's there, but they have to begin by coming up with the exploratory, how we're going to do it, what are the deliverables, and they divided New Mexico into regions, judicial regions, to come up with how to do the deliverables. So it's a beginning for us, and it's a good beginning. So just to let you know. So
Yeah,
Craig, you have a question for Dr. Insel?
I do. Thank you, Dr. Insel, for your, again, for your great book and for your presentation. I wanted to bring something up that you're probably familiar with, quite familiar with. The former Surgeon General of the United States, who you probably know, Dr. Vivek Murthy, wrote a book called Together, The
yeah,
Healing Power of Human Connection in a Sometimes Lonely World. And I found it really compelling because, in my opinion, it seems like we're much more disconnected and alienated from each other in the last 20 years with technology and even social media and things like that. And he makes the case that this is a critical part of mental health, is having and maintaining and building connection with each other in various forms. And I was just wondering if you would like to reflect on that a little bit.
yeah. Well, his book came out about a year before mine came out. I think that's right. And I know him well. We served together in the Obama administration, so we got to be pretty good friends. Um, I love that book. It was actually an inspiration for me to work on mine. I knew we were talking a lot when he was working on that one. But I think the thing that really drew me to it, it was this just the what you described, this idea that community is important and that we are social animals. We really do need connection. That the kind of connection, particularly for young people, that they seem to be seeking through social media, just ain't working. It just, it um, for whatever reason, it's just not what humans need, and it's leads people often to feel more lonely, not less lonely. Here's one before we finish. I mean, that's like I'm so fascinated by kind of the counterintuitive, the things that you think shouldn't work but do work. I just today got some of the data from a new AI company. So you have companies like ChatGPT and Anthropic, OpenAI and Anthropic that have built these foundational AI models that are now being used widely. And OpenAI's ChatGPT is being used by 800 million people every week. About 50% of those people say they're using it for mental health support or individual guidance or something like that. A surprising number of them are acutely suicidal. It's about 1.2 million every week talk about their suicidal thoughts and intent. So it's really, really troubling. At the same time, there are a couple of companies that have said that's super dangerous because these are models that weren't built with any insight into behavioral health care and therapy and what you need. That these are models that were built to sort of tell people what they wanted to hear, and that's not what therapy is. It's often telling people what they don't want to hear and haven't been able to hear if you want to be an effective therapist. So there's a model that I got interested in, built by a company called Slingshot, and they built a model called ASH with about 10,000 or 50,000 hours of psychotherapy. Looks very, very different from the foundational models like OpenAI's model. And in fact, when you compare them side by side, the bots give totally different answers to questions. And the ASH, the Slingshot bot, is actually quite challenging. They just came out with data yesterday that's and I guess it'll be published tomorrow morning, that shows that that on their platform, people who are using Ash actually become more social. That's over 50% of people make a new friend within 7 days of starting Ash, and they're spending actually less time online, not more time. So it does. Vivek and I used to say that the answer was turn off your screens, get out of the house, all of that. But this new data makes me think that maybe there's actually a way to subvert the screen, to actually get it to motivate people to close the computer and get out into the real world. I don't know. We'll have to see how well this works and see how far it can go. But I totally agree with the Surgeon General, former Surgeon General, that we need to really focus on community and connection. That's where ultimately, particularly for the youth mental health crisis, that's where the answer is. By the way, it's not often therapy. I do a Substack every week, and I did one a couple of weeks ago. I think the title was something like "An Elder's Thoughts About Youth Mental Health." And what I talk about in there is I'm not really sure that if the problem is internalizing disorders like anxiety and depression, sitting down and focusing on your problems with a therapist is probably not the right answer. What it is probably getting out and doing stuff, volunteering, helping others, and getting empowered to be useful in the world is probably more helpful than sitting and fulminating about your own mental health. So I'm not sure that we're giving that message to young people, but it's a place where I think we need to shift.
No, you're exactly right, Dr. Insel, about youth. And they become so isolated and they normalize their feelings, which can be really abnormal and very harmful. And they begin to think that what they're experiencing is real and everything else is not real. And that isolation is really not going in the right direction. I want to thank you so much. This was an
Yeah.
extraordinary presentation, and it really gave us a lot of food for thought and a lot of ideas. And actually, most important, you gave us a lot of hope. And your ideas and your endeavors and your thoughts for bringing mental health to the forefront of how we do this is really going to move the needle on how we do this. And with your permission, I may reach out to you again in another year and say, "Come on back. We need to hear
Yeah.
from you again."
Well,
And
hopefully that message will be even better at that point. But thanks for having me and good luck to all of you. And it's exciting with the money that's coming from the state,
yeah.
chance to do something really, really important here.